Session 3 covers practice settings of primary care physicians. We review the highlights about working life in the clinic, ER, urgent care, and virtual care, and walk you through an example of how a patient with the same concern would receive potentially different workup and treatment plans across these settings.
Most people are familiar with the standard outpatient clinic. This is usually a building, standalone, or part of the hospital system or in a little office park with other practices. The different types of clinics, regular outpatient primary care clinics, include private practice, which is usually defined as owned and operated by the physicians who are seeing patients in the clinic. Academic, part of a academic center. Hospital-based, pretty similar to academic, but usually a private hospital. A federally qualified health center, direct primary care, and rural health center. Now, most of these are all in the same type of building, but they look differently based on the populations they serve and the way they get paid. The most common type is your run-of-the-mill fee-for-service, or what we call, quote, traditional primary care. And what this looks like functionally is these doctors will have 10 to 15-minute slots, and that allows them to see about 20 to 35 patients per day on average. And frequently, these 10 to 15-minute slots are double booked, meaning that two patients will be placed in the same time period. For example, two patients at 9 o'clock. And we'll go more into why this happens in terms of scheduling optimization in Module 3. The next setting where primary care happens is actually the emergency room. And this is thanks to EMTALA, which is the Emergency Medical Treatment and Labor Act, which was passed in 1986. Essentially, EMTALA said that anybody who goes to an ER needs to be triaged. That is at least seen and assessed. What that meant is that a lot of people who were otherwise too poor or uninsured to go anywhere else would just wind up in the ER. One of the main issues is that emergency medicine's function is really to rule out scary stuff and not necessarily always diagnose anything. For example, if you go in with abdominal pain, nausea, vomiting, you may get discharged with a final diagnosis of nausea and vomiting. And some patients get frustrated by this because they go in, they pay a couple $1,000s, and they say, well, the doctor didn't do anything. Well, really, they did, because they ran all these tests, did the imaging, and you're not dying right now. Therefore, you're fine. And that's what emergency rooms are for. But because a lot of people couldn't get into private clinics or anywhere else, they just go to the ER for chronic med refills, for diabetes treatment. And so the emergency room became somewhat of a primary care center itself. And most emergency rooms, of course, are walk-ins. One of the reasons patients can't get into their regular fee-for-service traditional primary care office is because the slots are booked and they don't have any other recourse but to walk into an ER and just wait. And one interesting outcome from years of emergency room docs doing chronic med refills is that a lot of emergency room docs now are becoming burnt out. And so they're actually a good number of them quitting emergency medicine to usually join or open their own primary care office and actually act as primary care doctors, which their training is very different from most primary care specialty trainings. The other setting is urgent care. Urgent cares were actually started by emergency room docs who realized that there was so much low acuity, non emergent issues that walked through the ER that they could make a whole new business out of seeing patients who couldn't get into their primary care but really should not be in the emergency room. And since that time, urgent cares have really just blown up because it's a fantastic business model and there's definitely still a high need for it. Urgent cares are pretty aptly named because the idea is that patients get in and out quickly. They have something now and they get treated and they leave. Some urgent cares will also engage in primary care and actively market themselves as primary care centers. And one of the reasons is similar to how emergency rooms started doing chronic care management. It's that people would go to urgent care for their med refill or for sports or school physical, and they just kept going back for every issue. And actually, some of the urgent cares, the same doctors, even though they were doing shift work, would see the patients, or the patients would wait to see the same doctor when they were on their shift. But for some patients, it wasn't a matter of continuity of doctor, but at least all their data was there. And so these urgent cares would develop systems to do diabetes follow-up, lipid management, high blood pressure, and in a way would go from only doing quick, low acuity sick visits to also developing systems to take care of chronic care. And then just a special mention, there are specialized urgent cares now, including pediatrics and orthopedic surgery, where they only treat those certain populations or injuries or illnesses. And a final mention is virtual care. Of course, virtual care took off during the COVID pandemic, and now there's all different flavors of virtual care. Here, I want to highlight a dichotomy. There's virtual care that has no continuity and virtual care that has continuity. I would call no continuity the traditional virtual care, which started before the pandemic and took off during the pandemic. And these are companies like Teladoc and Amwell. It's basically a Microsoft Teams meeting urgent care visit where patients come in, sore throat, runny nose, burning with urination, that kind of thing. And the function of the no continuity virtual care is similar to urgent cares, where the doctors are just trying to get people through. And you'll find that a lot of the doctors that work for these companies are essentially burnt out docs who don't want to be doctors anymore, but still need to pay off their debt. And so they just sit there and click through patients as fast as they can and just prescribe antibiotics. Then, since the pandemic, there's been a bigger push and more development in the virtual continuity model, or also known as virtual first primary care or virtual primary care. A good example of that is Firefly. You have your team, including your doctor, your care manager, and any nurses. And every time you engage the platform, the same team sees you and takes care of you. So this is probably the closest to the traditional family medicine clinic, but virtually. And many of these will have video visits, but some companies like Galileo move to text first and are very heavily text based. And then there's the hybrid, which is virtual plus physical. So companies like Taito are allowing virtual only or virtual first services to also do a somewhat physical exam, in that the patient does their own physical exam and the findings are transmitted. So like a otoscope, where the patient sticks the camera into their ear and the image beams to the doctor. Or, for example, a stethoscope, which can go to rural settings without doctors, and the doctor or nurse coaches the patient where to put the stethoscope, and the sound will transmit to the doctor. Each of these practice settings is fairly different. And in fact, if you were one patient with a similar complaint, you could actually get a completely different workup and treatment plan based on where you go. So let's talk about, say, a 30-year-old female with dysuria, which is pain with urination. If you go into a clinic, common things being common, it's most likely a urinary tract infection, which in an office setting, you may or may not even check a urine test. Probably not a culture if there's no other risk factors, and prescribe one of the first line antibiotics. Pretty low cost workup, low cost treatment. If you go to emergency room, remember the primary function of the emergency room is to rule out the scariest stuff. Burning with urination could be all sorts of things. Anything from bladder cancer to kidney stone to kidney infection. And so when you walk in the ER with chief complaint of dysuria, sometimes you'll get everything from urine tests to blood tests and potentially even sent through what we jokingly call the donut of truth, which is a CT scanner, just to make sure there's no organ involvement or kidney involvement or anything happening in the belly. And then, of course, you'll still get the antibiotic, though sometimes the emergency room doctors go off some other guidelines, and their first choice of antibiotic is different than what we like to do in family medicine. Urgent cares tend to be a little more similar to the emergency room. They will test first, sometimes even before the provider sees the patient. So if you come in and it burns when you pee, you're going to get a urine. And then, of course, the treatment is fairly similar to outpatient clinic. Virtual is interesting because most of the time they will err towards not ordering workup in terms of labs, imaging, or anything, and they can't do a physical exam. So the virtual will generally try to screen for red flags, and absent red flags, they will follow the rule of common things being common and prescribe an antibiotic for urinary tract infection. I guess the one thing I want to add to clinic is that in clinic, the patient's likely also going to get a physical exam, probably pushing on the belly, make sure there's nothing going on in the belly, tapping on the mag to make sure there's no kidney involvement, something that virtual can't do. The 4 settings all do primary care today, but as you can see, they all have different purposes and different things happen within each one. And so it's important to know that a lot of how healthcare is viewed, how primary care is viewed, can be seen through different lenses depending on where a patient is seen and how they are treated in each setting.
To summarize, we just learned about various practice settings of primary care physicians: the clinic, ER, urgent care, and virtual care. And we provided an example of how care might differ across these settings for the same presenting symptom. This concludes session 3.